Hello, everyone. Thanks for joining me today for the Provisional Crowns and Restorations lecture. So to start, we're going to look at your objectives for this unit. And you can read through these and stop the lecture to look at these. So there are 5 on this page, 4 more on this page, and here are the last 6 objectives for fabricating a provisional restoration. So to begin this unit, you should have received the handout that is located in Brightspace that outlines each tooth's function, the morphology of each tooth, its traits, and its tooth classification of each of the incisors, canines, premolars, and molars. I also want you to read 2 separate pages in each of your textbooks, page 185 in your Modern Dental Assisting textbook, as well as page 327 in your Dental Materials textbook, to review the function and form of the periodontium, to help you understand why some of the criteria is what it is when we discuss it in a moment. So some anatomical features that protect the periodontium, one is called the height of contour, which is simply the crest of curvature or the shape of the tooth. So we have a couple different heights of contour. We have the facial and lingual contours, which are the pronounced curvatures that provide natural passageways for food. It also protects the gingival tissues from food impaction during chewing, and it provides adequate stimulation for the tissue but protects the gingival tissues from trauma. The mesial and distal contours help to determine normal contact and form the embrasure between the teeth. The mesial and distal contours also aid in self-cleansing of the tooth and for self-preservation of the tooth. When you're fabricating a provisional, it is critical that the tooth be restored to its original contour. Contact areas are the proximal height of contour, is where the tooth from a facial lingual view is contoured so that it is wider near the occlusal surface and narrower near the gingival surface. Adjacent teeth do touch at their widest points, which is the contact point. So this is where, when you're flossing your own teeth, the floss is going to be snapped or pushed through that contact point. These help to keep food from being trapped between the teeth. They help to hold the teeth firmly in alignment, and they also protect the interdental papilla of the tissue. Embrasures are those interproximal spaces, and these occur when 2 teeth in the same arch contact. Their curvatures next to the contact areas form spaces called embrasures. These are triangular spaces in a gingival direction between the proximal surface and 2 adjoining teeth in contact. So if you look on this picture, there are lingual and facial embrasures when you're looking down on the occlusal table of the teeth. And there are also gingival embrasures that happen beneath the contact or apical to the contact of each of the teeth. Occlusion is very important when you're fabricating a temporary or provisional restoration. A couple of things to remember is that we have some terms called centric occlusion, which is also another name for intercuspal relationship. This is when the patient is biting with normal occlusion. Their teeth are resting together. And when we're looking at this in normal situations, the lingual cusps of the posterior maxillary teeth fit into the central fossa of the occlusal surfaces of the posterior mandibular teeth. And I'll show you a picture of this in a second. And then we have lateral excursion and protrusion of the mandible. When someone moves in a lateral motion, this is where they slide the mandible to the left or the right in centric position. So they just simply move their mandible to the side. In protrusion, the mandible is placed as far forward as possible from the centric occlusion. So in the top picture of the full arch of model, you can see that the maxillary teeth, the lingual cusp, are going to be sitting right in that central fossa of the lower teeth. The maxillary incisors are on the outside of the mandibular incisors. And on the bottom of the page, you see centric, protrusion, and lateral. excursions. We have person biting normally. You can see their cuspation here. The maxillary teeth are on the outside. Here's where they're pushing their mandible far forward, and here you can see midline. So the person is in a right lateral excursion for that example. Occlusion gives, we can find occlusal values when the patient does exaggerated motions to simulate the actual movements of their mandible, when it functions during mastication, when they bite, such as they're biting off a sandwich, yawning, and speaking. If a patient notices premature contact, which can be called high bite or hyperocclusion, this issue may cause pain or damage to the prepared tooth or also to the opposing tooth. All right, so to introduce you now to making a temporary, because fabricating provisional coverage is an important component of fixed prosthodontic treatment. When a person has a fixed prosthesis prepared several times, they need to have that item sent to the laboratory, so we need to make sure that the tooth is comfortable and safe during the fabrication of their permanent restoration. So the criteria for the provisional coverage is to maintain the prepared tooth position relative to the adjacent and opposing teeth. As you are aware, the tooth is not cast in stone, but in tooth, which is a living tissue. So the bone is able to move that tooth mesially, distally, lingually, buccally, occlusally, for that tooth to be meeting its opposing tooth, which is what it always wants to do. So that temporary crown needs to keep it in contact with both mesial, distal positions and occlusal positions. We also want to use our temporary to protect the tooth from the tooth surfaces and margins so that they are not fractured during the time the patient is wearing that provisional, to protect the gingival tissues, to provide function and aesthetics, and to also be retained for just the right amount of time. So these provisionals may be required in general, pediatric, endodontic, and prosthodontic cases. And there's a couple different examples here, intracoronal and extracoronal cases. The patient wears the provisional coverage to protect the tooth for a short amount of time. The criteria for a properly placed provisional restoration includes maintenance of the tooth position, protection of hard and soft oral structures, and to establish function and aesthetics for the patient. When the tooth is prepared, the dentinal tubules are exposed to potentially harmful thermal, chemical, mechanical, and bacterial effects in the oral cavity. So the insulation virtually is stripped off of the tooth. All of the enamel is gone and much of the dentin is exposed, which is why the tooth becomes sensitive if the temporary is not placed adequately. These open tubules leave the pulp vulnerable to the effects of temperature and to the chemical irritants of the material that was placed over the tooth. So we need to remember that the materials that we fabricate and place over this exposed tooth must be biocompatible, and they must be well adapted to the preparation to provide all of the criteria we mentioned earlier. To maintain a tooth position, we need to remember that when a tooth is prepared to receive a crown, sufficient tooth material was also removed to create a space between that adjacent tooth and the opposing teeth. So a prepared tooth without occlusal or incisal and proximal contact may migrate either laterally or occlusally within only a few days. We need to also remember to protect our gingival tissue. Most crown preps extend subgingivally slightly, making the margins and the overall contour of the provisional restoration critical to periodontal health. Periodontal tissues are susceptible to irritation from an over-contouring of the temporary or an under-contour if there's overextension or overhanging margins. And here are a few examples. So in this visual, we have the top picture is a temporary placed, and there's adequate contouring of the temporary. It allows food to flow over the sides of the teeth and not smush or traumatize the soft tissue. The middle illustration of B has an under-contoured temporary, which allows food to jam itself right into the soft tissue at the base of that temporary crown. It does not protect the soft tissue at all. And in C, the bottom picture, the temporary is over-contoured, which allows the food to flow away, but then it also has a very large trap or plaque to be retained in the crevices at the sulcular level. Overextension or underextension of the margin can be just as detrimental. So here again, we have an illustration. We have the temporary crown, we have the tooth and the preparation, and here we have this large overextended margin onto the tooth. So we have, again, an area of bacteria that can stay here, food can get caught here, and it's not protecting the gingival tissue if that toxic bacteria can get lodged there. In the middle example, we have adequate amount of extension here, but in this example, we have an underextension, so it doesn't protect the margin of the tooth preparation. The crown is short, the margin is exposed, and could be fractured during the time that the patient is wearing their provisional. If that was the case and the margin was fractured, the temporary had not protected it, and the permanent crown will not fit adequately, and the patient will be susceptible to secondary caries. Here are examples of overhangs on crown margins. These do not happen to be provisionals. These are actually permanent crowns, and these green arrows look at both of these two examples of overhangs. Here on the mesial of the premolar and the distal of the molar. So we have this gigantic overhang, and this tooth actually has a very large area of caries that's forming. So this patient is in a world of hurt. Upper has a broken off tooth. So this person's going to be sitting in the chair for a while to be restored. Dental procedures that may require provisional coverage, we have general dentistry. So we have a person who needs to have a tooth prepared, but they're leaving for several weeks or a month to go in the military or go on a vacation, or something that they're sick, COVID-19 strikes, and they can't get back in. So we put a provisional coverage on the tooth until we can schedule them back into the office. Pediatrics use provisionals, also endo. We use provisionals to get the person back to their general dentist, and obviously for prosthodontic work, we have provisionals for crowns, bridges, implants, all sorts of things. Provisional is just a name that you should understand is worn for a short period of time. It is not a permanent restoration. The properties of provisional materials need to have adequate strength and hardness. They need to be compatible with soft and hard tissues. They need to be somewhat aesthetic, especially if we're placing them in aesthetic regions of the oral cavity, and they need to be easy to handle as well as relatively inexpensive. So materials used to fabricate these restorations must have properties that comply with the specific requirement of the situation and area in which they are placed. The strength and the hardness are important for posterior teeth, and aesthetic concerns are important for many applications, especially in the anterior teeth, but also in some posterior cases as well.